will now like to request session chairpersons on stage, Dr. Ashok Agarwal, Senior Surgeon and National Vice President IMA, Dr. Subodh Jain, Senior Consultant Physician and past President Allahabad Medical Association, and Dr. R.K. Yadav, Senior Physician and former Professor, Motilal Nehru Medical College, Prayagraj. I will request the speaker for the session for the oration, Dr. Ashish Duggal, Professor and Head of Department of Neurology, RML Hospital, Delhi, to please come on stage. Thank you. I would now request the chairpersons to please introduce the speaker for the oration, Professor Dr. Ashish Duggal, to the gathering.
A very good evening, I should say now. Dr. Ashish Duggal is Professor of Neurology at AVVIMS and Dr. Ram Manohar Lohia Hospital, New Delhi. He is in charge of headache clinic and autoimmune neurology clinic. He has been trained at Australia, New Zealand Headache Master School, Sydney. To his credit, there are more than 60 publications in peer-reviewed national and international journals. He is treasurer and founder member of Headache Society of India. He is ex-convener, Headache subsection IAN, and ex-member of Executive Committee, Delhi Neurological Association. He has many awards to his credit, an eminent medical and health education teacher award by the Delhi Medical Association. So he will be speaking on a very common topic which we encounter in our day-to-day practice, that is peripheral neuropathy. Dr. Ashish Duggal, sir.
And it's a great honor for me to be delivering this Dr. Neogi's oration, although I never met him personally. It was my misfortune. Should have met him sometime. But anyways, he's been, as you told, he has been a pillar for the Allahabad Medical Association. It's a really great opportunity for me to deliver this oration named after him. So I'm going to talk about peripheral neuropathies, and I hope that I am not ragged as much Dr. Gulab was. So the learning objectives here are when we encounter a patient who we think has a neuropathy-like illness, so how do we identify whether a patient has neuropathy? Then neurology is all about patterns. So we need to identify patterns so that we can approach to localize and diagnose those neuropathies. Then we will do, I will present some cases. This will be a case-based discussion where we will try to decipher some common causes of neuropathy and what are the therapeutic options that are there. So basically when we talk about neuropathic disorders, this could involve either the sensory part or the motor part. In the motor part, there is a neuron and then there is a motor nerve. So it could be either a motor neuronopathy, which is motor neuron disease, or a sensory neuronopathy or a ganglionopathy. Then if the nerves themselves are involved, then they are further divided into either axonal neuropathies or demyelinating neuropathies. So the axonal neuropathies would be either large fiber, large and small fiber mixed, or only small fiber. And the demyelinating neuropathies would be, could be again sensory or motor. So the clinical manifestations are, when we see neuropathy, there could be motor manifestations, there could be sensory manifestations, there could be autonomic manifestations. And in both motor and sensory, there can be positive or negative phenomena. For the negative phenomena are very easy, we all know, but what are important are the positive phenomena that can occur in a patient with neuropathy. So for motor neurons or motor nerve disease, there could be weakness, fatigue, and wasting. But then there could be positive phenomena in form of fasciculations or myokymia, which we should be aware of. Fasciculations we all know, but myokymia is another thing which we should be aware of. And I will be discussing it in the further slides. And for sensory, again, there can be negative symptoms such as sensory loss or positive symptoms such as paresthesias and dysesthesias. So what about the motor manifestations? So a typical neuropathic patient will present with a distal onset of weakness type of presentation. So initially, they will have weakness in the foot muscles. So they could have tripping on the carpet or curb. They can have a high steppage gait. They can have difficulty in holding on to slippers or wearing the slippers. So these are the initial symptoms a patient with neuropathy who has a motor manifestations will present. Then later on, the symptoms can progress to the upper limbs, and then they will have difficulty in manipulating doing fine movements with the hands. So they can have difficulty in using buttons or zippers, turning the keys in the lock, and general fine movements would be there. And as the neuropathy progresses, usually the weakness will progress to the proximal part, and then later on, the patients can have difficulty in getting up from squatting position. They can have difficulty in moving their hands, arms upwards. And the weakness is usually proportional to the motor neuron loss, and usually occurs when almost 50% of the axons have been lost. So by the time a patient presents with these kind of complaints, significant damage has already occurred, so we need to be identified early so as to prevent further damage. And as I told, this will be a distal to proximal involvement. Then the second manifestation, motor manifestation, is atrophy. And again, this will take time for developing, and it usually occurs in 90 to 120 days after the onset of disease, which may not be very clear usually, and the patient can sometimes present with atrophy. And it will reduce the muscle bulk by almost 75 to 80%. It's important to remember that in neurogenic conditions, weakness and atrophy usually go in hand. If there is a rapidly progressive disease such as GBS, their weakness will be much more than, weakness will occur much more than atrophy. On the other hand, where there are slowly progressive degenerative diseases, for example, ALS, which is a motor neuron disease, so there is neuronal involvement of the motor neurons, their atrophy would occur before weakness, but they will be more or less similar. If weakness is much more than atrophy, and this is important because it helps us in differentiating myopathy from neuropathy, it indicates that this is myopathy. So in myopathy, atrophy will occur late and weakness will be much more than atrophy. But on the other hand, if you get a patient who has atrophy much more than weakness, then this is usually a non-neurological condition. And what I'm showing here is in atrophy of the first dorsal interossei. So in upper limbs, besides measuring the muscle bulk, what is important is to look for specific muscles which may provide some clues. So the involvement of the first dorsal interossei, this can be weak when the upper limb nerves are involved. And another important muscle is the extensor digitorum brevis. So this again helps in differentiating neuropathy from myopathy. If EDB is wasted, this indicates a neuropathy. If EDB is preserved, as you can see in this figure, this is not a neuropathy, most likely a myopathy. Then there could be positive motor symptoms. These are usually in the form of cramps, जिसको हम हिंदी में बाउंटे बोलते हैं. So these can be present in ALS, sometimes in hereditary motor neuropathies, and syndrome of peripheral nerve hyperexcitability known as ISAC syndrome. Then other positive motor symptoms are fasciculations and myokymia. So fasciculations we are all aware of, and this video shows myokymia. So these are twitching movements occurring rapidly in the muscle, as you can see here. So these are essentially grouped fasciculations. So they have almost the same significance as fasciculations, but they are grouped fasciculations occurring in multiple muscle fibers, which are seen as a rippling sort of a movement in the muscle. And these indicate that there is some peripheral nerve hyperexcitability, which could be either primary, such as an ISAC syndrome, or it could be secondary to any neuropathy. For example, in CIDP, sometimes you can even get these in hereditary neuropathies. Now, coming on to the sensory symptoms. These are very common symptoms. Sometimes these patients can have neuropathy, sometimes they may not have a neuropathy. But the sensory symptoms again will have a positive and a negative symptoms. Positive symptoms are like tingling, pins and needles. Very commonly patients present with these kind of complaints. These indicate large fiber involvement. On the other hand, burning, jabbing and shooting type of pain, that indicates small fiber involvement. And the negative symptoms will include ataxia. The signs would include hyporeflexia or areflexia, decreased joint position sense, decreased vibration sensation, all these indicating that the large fibers are involved. And when there is decreased pain sensation and decreased temperature sensation, this indicates a small fiber involvement. So basically, one important point is about the positive sensory symptoms. So if there are a lot of positive sensory symptoms in addition to the sensory loss, this indicates that there is a acquired neuropathy, right? On the other hand, in inherited neuropathies such as Charcot-Marie-Tooth disease, the positive sensory phenomena are usually absent. So a patient who has profound sensory loss, profound weakness, but does not have any positive sensory phenomena or very mild positive sensory phenomena, always think of inherited neuropathy. And paresthesias and dysesthesias, basically paresthesias mean any uncomfortable sensation, and dysesthesias mean painful sensations. So this is how we differentiate between paresthesias and dysesthesias, and mostly they indicate, paresthesias usually indicate a large fiber neuropathy, and dysesthesias usually indicate a small fiber neuropathy. Right, so coming on to the negative sensory phenomena, we are all aware of. Patients can complain of cotton wool sensation, like they will say कि जब चलते हैं तो ज़मीन गद्दे जैसी लगती है या लगता है रुई पे चल रहे हैं, slippage of slippers without awareness, and the very often quoted sink sign where the patients, when they close their eyes while washing their face, they suddenly feel imbalance, may even fall down. On the other hand, small fiber deficits, there would be painless injuries, they may burn themselves and they will never realize that, and then they can have tactile anesthesia where they will have inability to feel the clothes or light touch. And this is another sensory symptom. So this patient, you will see, he has involuntary movements of his hands, right? And when we ask him to close his hands, close his eyes, these movements will worsen. So this is known as pseudoathetosis, basically athetoid movements which are occurring because of proprioceptive sensory loss in the upper limbs. This, you could call this as a Romberg sign of the upper limbs. In Romberg sign, we ask the patient to stand and then ask to close his eyes. There is an increase in swaying, and they may fall or close their, open their eyes. When these closes, this movement significantly increases. This is pseudoathetosis, indicating that there is significant proprioceptive sensory loss in the upper limbs. Then whenever I see a patient who is suspected to have neuropathy, always ask for some these important autonomic symptoms, whether there is anhydrosis, whether there is heat intolerance, gastroparesis, any bladder and bowel dysfunction, any history of erectile dysfunction, lack of tears or saliva, any intolerance to light. A pupil examination should always be done to look for AD's tunic pupil, and the blood pressure should be measured to look for any evidence of orthostatic hypotension. And then there are certain clues which point that this patient has a hereditary neuropathy rather than an acquired neuropathy. And this differential diagnosis is very important when we are seeing a patient with neuropathy. So any bony deformities like high arch feet, hammer toes, claw hands, wasting of the muscles of the distal foot, distal lower limb, champagne type of legs where the lower leg is very thin but the upper inverted champagne where the upper thigh is thick but the ankle and the calf muscles are significantly wasted. Then there could be, sometimes these may not be present, but there could be history of difficulty with running, sports or military activities, particularly in the childhood. So patients may say that they, in the childhood, they lagged behind their peers, they were not able to climb trees or jump from in the ground and other things. So कूद नहीं पा रहे थे, चल नहीं, भाग नहीं पाते थे, रेस में पार्ट नहीं ले पाते थे. They may have required braces to use. They may have a wrong history of arthritis or poliomyelitis. Sometimes may have been mislabeled as poliomyelitis when actually it has been a hereditary neuropathy. And they could have difficulty in walking on heels and toes. So these are some clues which will come from the history and from the examination, which will point that this is a hereditary neuropathy. So after looking at all these history and examination, what we are trying to do is we are trying to, make a pattern recognition. So what systems are involved? Whether this is either motor, sensory, autonomic, or in combination. What is the distribution, distal, proximal, distal plus proximal? What is the sensory nature? Whether this is large fiber, small fiber, or combined large fiber and small fiber. Are the UMN signs present? So after an examination, if there is, let's say, you usually won't expect hyperreflexia or even normal reflexes in a neuropathy. But if there are hyperreflexia, that indicates that there are some UMN signs present, then probably it's not a pure neuropathy, it's a myeloneuropathy. And what is the temporal evolution? With the acute, for in neuropathies, anything less than 4 weeks is acute, 4 to 8 weeks is subacute, and more than 8 weeks is chronic. So this is how we define the temporal evolution. And is there a hereditary clue? So after this, what we usually do is, we do an NCS. And the nerve conduction studies are basically an extension of the clinical part. And we try to divide into axonal or demyelinating. So axonal neuropathies on NCS will have a low compound muscle action potential, but the velocities and the latencies will be normal, or more than 70% of the lower limit of normal. On the other hand, when a demyelinating neuropathy, the compound muscle action potential would either be normal or slightly low, but there will be a significant decrease in the velocities, the distal motor latencies, and the F-wave latencies. So broadly, if the CMAP is low, it's axonal, and if the velocities are low, but latencies are high, distal motor latency and the F-wave latency is high, that indicates that this is a demyelinating neuropathy. Although in clinical practice, there may be some overlap, so patients with demyelinating neuropathy can have some axonal features, particularly when they come late in the course of the disease. But then an examination and history would probably give you clues, as we will see later when we discuss some cases. And on the temporal evolution, this is very important because acute neuropathies, mostly the most common cause is, which we see is either GBS, vasculitis, diphtheria, or porphyria. And in subacute cases, again, it could be inflammatory or toxic and nutritional deficiencies. This is the most, usually the garden variety of neuropathy. But sometimes inflammatory conditions like subacute inflammatory demyelinating polyurethral neuropathy can present as a subacute presentation. And finally, chronic. So the key etiology here is CIDP, which is treatable. And most important, most common is probably diabetic neuropathy. And then the hereditary neuropathies, never forget paraproteinemias in a patient with neuropathy and uremias. So now I will present some cases. So this was a 25-year-old male who, in the childhood onset, he had since 4 years, he has slowly progressive course where there was distal lower limb onset, slippage of slippers, restricted ankle movement, pes cavus and clawing of lower limb toes, distal lower limb weakness in the form of dorsiflexion and plantar flexion weakness, and sensory loss, 50% reduction in sensations below the knee. Upper limb was entirely normal. Now this patient, I hope if you can see this, the velocities are very low. They are in the range of 19 to 20. Normally, velocities should be more than 35 in the upper limbs, 30 in the lower limbs. So these are very low velocities. So that, and the amplitudes are more or less preserved, not very low, but slightly low. So this, with such low velocities, this is a demyelinating neuropathy. In a child, since 4 years of age, he has been having gradually progressive distal onset weakness with distal onset sensory loss. Now, his CSF was done, which showed a very high protein. But because he had significant pes cavus, clawing of lower limb toes, this indicated that there was this is an hereditary cause because he has a very long history. So when we did a genetic analysis, this was Charcot-Marie-Tooth disease 4C. So we often do CSF in patients with neuropathy, especially demyelinating neuropathies, but always when we are looking at the CSF, always look at it with the clinical context because this patient had a very high CSF protein and a demyelinating neuropathy. So very easily someone could have made it an acquired neuropathy. But because the temporal profile and the clinical finding, there was significant history of genetic clues that this is genetic neuropathy. This was actually a hereditary neuropathy rather than an acquired neuropathy. These patients will probably could be mismanaged as GBS or mismanaged as CIDP, and this should be avoided. Now, this is another case. This was a diabetic patient. He presents with paresthesias and dysesthesias in the lower limb, which gradually worsen so that they reach up to the knee. Then he later on develops these similar symptoms in the upper limb, fingers as well, and has also noticed that there is weakness in the lower limb, which initially occurred in the lower limbs and then gradually involved the upper limbs. The cranial nerves were normal. There was mild distal weakness in the lower limbs. Sensation was lost at the great toe, but JPS was lost at the great toe, but it was normal at the ankle. And the deep tendon reflexes, the ankle was absent, knee was decreased, upper limb was normal. And in the presence of diabetes, very clearly the diagnosis looks like diabetic sensory motor neuropathy. So these are dying back neuropathies or length dependent pattern, which is the usual classic pattern of a neuropathy. Most of these patients will present with a glove and stocking type of sensory loss. So the sensory loss will begin in the lower limbs. When it progresses to the mid-ankle or mid-knee or mid-leg, then these patients start developing symptoms in the upper limb. So this is known as glove and stocking type of sensory loss. The motor weakness also follows the same path. And basically in this pattern, that is, I don't know who that is coming, but this is a length-dependent pattern. The top etiologies remain diabetes, metabolic, toxic, and hereditary. So for metabolic, this could be in these patients, there could be vitamin deficiencies like thiamine deficiency, B12 deficiency. Genetic, I told you, could be hereditary motor neuropathy. And diabetes, diabetic neuropathy remains the paramount cause. So these are the investigations that you should order initially in a patient who has a distal length-dependent neuropathy. Always look for diabetes if it is normal, and glucose tolerance test should be done, B12 deficiency. In all these patients, especially patients with who are aged more than 50 years, evaluation for paraproteinemia should be done. At a minimum, serum protein electrophoresis, but ideally serum immunofixation should also be done. And then, depending on if there are other features present, we could evaluate for a genetic testing. Sjogren syndrome remains an important cause, so ANA, SSA, SSB should be done if other things are normal. And if everything is normal, then probably a CSF or a sural nerve and a sural nerve biopsy would be indicated. And the hereditary neuropathies, which a case I showed, they can be of two types, CMT1, which is a demyelinating one, and CMT2 basically, which is axonal one. So the next, this is a case in 18-year-old male who developed rapid onset weakness, both distal and proximal, starting almost simultaneously. And there was some sensory loss also, so cranial nerves were normal, and power was 1/5 in neck, all limbs, neck was also weak, and there was some sensory loss in the lower limbs, feet in the hand, and deep tendon reflexes were all absent. So he developed symptoms and reached nadir within 3 to 5 days. So this is the classic presentation of Guillain-Barré syndrome. The NCS showed, again, reduced conduction velocities. These are the F-wave graphs, and you can see there are no F-waves present here. So this was a demyelinating type of neuropathy, acute inflammatory demyelinating polyradiculoneuropathy. And this is the second pattern, which is length-independent pattern. So here the weakness and the sensory weakness predominantly starts in the distally, may start distally, there could be an ascending pattern, but very, very rapidly involves the upper limbs also and the lower limbs proximally also. So this is a length-independent pattern. So unlike length-dependent, where there is a gradual progression over from the lower limbs distally to proximally and the upper limbs, this involves distal and proximal almost simultaneously, and both are involved almost equally. So these are the diagnostic criteria for GBS. I will not go into detail, but all of you know probably. And it requires, but there should be acute areflexic quadriparesis, or paraparesis, which reaches its nadir within 28 days. So acute for GBS, it's only 28 days. CSF protein is usually high. Nerve conduction may show demyelination or axonal pattern. And these are some variants of GBS. So it's important to remember GBS can present with focal presentation. So patients can present just with bifacial weakness. They can have a paraparesis. They may not have an upper limb weakness. They can have pharyngocervical brachial variant, where they can have only weakness of the neck and the upper limbs and some bulbar dysfunction. So there can be several variants. One variant is MFS, where there is involvement of ophthalmoplegia, ataxia, and areflexia. Now coming on to the treatment, we all know plasma exchange and IVIG are the mainstays of treatment, although some people advocate that steroids can also be given, but textbook-wise, it's plasma exchange and IVIG. Plasma exchange for ambulatory patients, sometimes you can get patients with GBS who are ambulatory. So if they are within the first 2 weeks of presentation, IVIG or plasma exchange, both can be given. But if they are come after 2 weeks of presentation and they're still ambulatory, then there is more evidence for plasma exchange than for IVIG. Basically, what IVIG and plasma exchange will do, they will halt the course of the disease, arrest the course of the disease, and then later on, there will, with continuous rehab, there will be improvement in the motor and the sensory function. There are certain controversies. What do you do if a patient has received IVIG and he does not improve? So is there an evidence for a repeat course of IVIG or doing a plasma exchange after giving IVIG? So presently, there is no evidence to use a repeat course of IVIG or use either use a plasma exchange. Another important thing is when you are using IVIG, at least for 3 weeks, there is no point in giving plasma exchange because all the IVIG will be washed out by the plasma paresis. But if there is a patient who has received IVIG, there was a transient stability, but then worsens again, this is known as treatment-related fluctuation. And in these cases, whatever treatment has been given earlier, whether it was IVIG or it was plasma exchange, can be repeated and should be repeated because this is different from a person who is not responding. So this is how we will manage GBS. Now coming on to the next case, this is again a length-independent pattern. This patient had distal weakness, started as distally, but very rapidly involved the proximal muscles. Distal and proximal involvement was almost similar. He reached a center within 15 to 20 days and was diagnosed as GBS. He was given IVIG, but there was some stability, but he then worsened again. And within a short period, he became bedbound. He was given another course of IVIG. There was again some stability, but continued to worsen. Finally, he was referred to us. And when he came to us, he was carrying this report of neurofascin 140 positive. So neurofascin antibodies are a new thing in neurology, neuropathies. So these are antibodies against the nodes and the paranodes of the nerves. And in these patients, these could be IVIG non-responsive. So a patient with CIDP or an acute GBS who is not responding to IVIG, some of them may be neurofascin positive. But the problem was that he was isolated NF140 positive, and there are these NF140 alone has less significance. And continuously he was worsening. We repeated that NF140, that came out to be negative. It was probably positive because he had received IVIG earlier, and IVIG led to a false positive NF140. His nerve roots were thickened, as you can see in this MRI, and the velocities were slightly on the lower side. There were F waves were absent, and the latencies were increased. So this patient was diagnosed as chronic inflammatory demyelinating polyradicular neuropathy because the progression of the course was lasted for more than 2 months. So this was diagnosed as CIDP. He was started on IVIG and steroids, and he improved. So CIDP, basically, typical CIDP is proximal plus distal weakness in the upper limbs and the lower limbs with distal sensory loss and a demyelinating type of electrophysiology. But again, just like GBS, there can be certain other variants. For example, MADSEM, where there will be asymmetrical multifocal sensory loss and motor loss. Then, in contrast to the typical CIDP, there could be a DADS variant, distal acquired demyelinating syndrome, where the weakness is predominantly distal. But how to differentiate it from a DSPN, the distal sensory motor polyneuropathy? There, the weakness in the lower limbs comes first, and when it progresses to the mid leg, then the upper limbs get involved. In DADS, on the other hand, both the lower limbs and the upper limbs, the feet and the hand, get involved almost simultaneously, and the distal motor latencies on the nerve conduction are very high. And then there could be pure sensory or pure motor CIDP, where there are just sensory or motor symptoms, but these patients usually evolve into typical CIDP. Regarding the treatment is steroids, IVIG, and Plex for CIDP. Usually we start with steroids or IVIG depending upon the comorbidity. So if a patient has diabetes, we would avoid steroids. And then for maintenance, we will be using azathioprine and mycophenolate. And for refractory cases, we will be using steroids or IVIG. So this is another case. This patient had predominantly distal sensory. I think I had more time probably. So
you can go ahead for 2 minutes more.
I have a lot of slides. I was told 45 minutes. I've completed that. Okay, I will try to finish it quickly. So this patient, what we see in this patient, there were distal sensory symptoms in the lower limbs. Then there was a lens-dependent sort of a pattern. Basically, it started distally, then involved the proximal lower limbs and the upper limbs. But when we did the nerve conductions, the velocities were very low. So whenever patient has a distal lens-dependent type of pattern, but the conductions are showing a demyelinating pattern, always suspect POEMS, which is a syndrome where there is polyneuropathy, organomegaly, endocrinopathy, M protein, and systemic symptoms. So POEMS, this patient had a sclerotic lesion in the sacrum, and there were multiple lytic lesions with sclerotic margins, and IgG lambda monoclonal band. So this was POEMS, and this forms a very important differential of CIDP. I will skip probably some of the cases then. This patient had an asymmetric onset, initially developed a lower limb foot drop, painful foot drop, then he developed bulbar symptoms, and then he developed symptoms in the hands. So this was an asymmetric multifocal type of presentation, initially a foot drop, then a weakness in the radius extensor of the hand, and bulbar symptoms. Everything was negative. There were multifocal involvement in on the nerve conduction studies. And this patient had a non-systemic vasculitic neuropathy. On biopsy, there was vasculitis in the muscle and the nerves. So this was a non-systemic vasculitic neuropathy. And this is another case where 38-year-old male who had 1.5 years of progressive numbness in the right thumb and the index finger. And then he developed weakness in the right hand and wasting over the thinner eminence, as you can see here. He had thickened nerves. This is the thickened median nerve. This is the thickened greater auricular nerve. So whenever there is a patient with multifocal asymmetric onset, always palpate the nerves. This patient nerves were thickened, and a biopsy from the median nerve showed that this was leprosy. This is MR neurography, which is again showing thickening in the brachial plexus as well. So this is the next pattern. This is mononeuritis multiplex, which could be either ischemic or due to infiltration. These are the two most important causes. So if ischemia, that could be vasculitis. Now vasculitis could be either a systemic vasculitis or it could be a non-systemic vasculitis, as was in the case earlier. But for systemic vasculitis, always look for NCA, CNCA, PNCA and all. And for leprosy, always look for the enlarged nerves, do a slit skin smear, and if not, it's negative, then do a fascicular nerve biopsy or a nerve biopsy to look for pure neuritic Hansen's, and then they are treated accordingly. For vasculitis, we usually give steroids, followed by either rituximab or cyclophosphamide as maintenance therapy. Then this is another asymmetric presentation. Patient presented with severe pain in the shoulder, and as the pain resolved, this patient developed weakness in the arm. So he had difficulty in raising his arm upwards. There was weakness of the deltoid, the supraspinatus, and the infraspinatus. This is a classical presentation of idiopathic brachial plexus neuritis, where patients present with pain and then they develop weakness in that particular limb. This is important to identify because this is often missed. Steroids can be used in the early part of the disease. They will relieve the pain. They may not help much with the weakness. And in those cases where weakness persists, rehabilitation is important. So this is the pattern 3 and 4. There could be multifocal, as you can see here. There could be involvement of the single nerves, or it could be involvement of the multiple nerves. And then plexopathy, where there is involvement of the entire limb. So these are the pattern 3 and 4. This will be my last case. So this is a 25-year-old female. She had predominantly asymmetric sensory symptoms. Initially started in the hand, then gradually involved in the other hand, then the lower limb. Then she developed numbness over the face. And nerve conduction again showed that all the snaps are absent, but the motor nerves are all normal. So their motor examination was also normal. So this is a pure sensory asymmetric type of presentation, which is a classical presentation for a ganglionopathy or a sensory neuronopathy. This patient, SSA, SSB were positive. Her lip biopsy also came out to be positive. She was diagnosed as Sjogren syndrome. So Sjogren syndrome can present as ganglionopathy. It's a very classical presentation which you need to identify. Basically, the sensory symptoms would usually start in the upper limbs. They will be asymmetric, and there will be patchy sensory loss. So this is the pattern 5 that you need to remember. And besides Sjogren syndrome, the other causes could be paraneoplastic, especially anti-Hu antibodies, idiopathic, and pyridoxine toxicity. And how do you differentiate a large fiber sensory neuropathy from a ganglionopathy? In large fiber sensory neuropathy, again, there will be a glove and stocking type of sensory loss. In this, there will be an asymmetric, patchy, non-length dependent sensory loss. Finally, just a few slides about this has already been talked about how to manage neuropathic pain. So I will not go into detail, but these are the drugs that we use. But what I would like to stress on is that what Dr. Gulab already told also, that you should always slowly build up the dose, because if you start the dose at a very high dose, then these patients can have significant drowsiness and dizziness, and build up slowly with aiming for a target of 30 to 50% relief over time. And once pain relieves, then try to withdraw after 6 months. And the drugs have already been discussed. So what are the, finally concluding my slides, whenever we are approaching a patient with neuropathy, first try to identify what symptoms are involved, whether it's sensory, motor, or autonomic. Then try to decipher the distribution. Always try to find whether it's length dependent, length non-dependent, which is usually an acquired demyelinating neuropathy, mononeuritis multiplex, or asymmetric multifocal type of presentation, which could be ischemic or infiltrative, such as leprosy, and non-length dependent pure sensory, which is a ganglionopathy. So these are the patterns which you need to identify. Then the temporal profile. Always ask about occupation, drugs. Look for systemic signs, especially hypopigmented patches. In elderly, always do a serum protein electrophoresis and immunofixation. On these patterns, try to evaluate to make a diagnosis. Try to identify the treatable conditions such as CIDP, paraproteinig neuropathy, vasculitis, and Hansen's disease. And this is how we'll try to approach and manage a patient with peripheral neuropathy. So, thank you.
Hello. Thank you, Dr. Ashish, for your outstanding presentation.
Thank you.
And the session was highly informative and clinically relevant. And we thank you for your valuable contribution to this conference.
Thank you.
Thank you.
Are there any questions? Yeah. Dr. Kachnar.
We got a very interesting nerve biopsy, and it was the patient presented with the peripheral neuropathy. And what we saw, which we didn't expect also, we saw amyloid deposition. Amyloid deposition. So it was amyloid-associated neuropathy, which we reported it as. So just your comment on when do you advise a nerve biopsy? And is there any experience of yours on amyloid-associated neuropathies?
Okay, so first question, when do you advise a nerve biopsy? So currently, in the current scenario, probably the most important indication or the sole indication would be when you have a mononeuritis multiplex type of presentation. Because those are the conditions where anything else probably may not come up. For example, I showed you that NSVN case, everything was negative. So only diagnosis came on now biopsy, and when he received steroids and rituximab, there was significant improvement. So this is the major indication. The second indication would be probably a refractory CIDP. So you have diagnosed CIDP, you have ruled out paraproteinemias, the patient is still not responding. In those cases, probably a nerve biopsy would be indicated. You have tried cyclophosphamide even, and then you don't get, this patient is not responding, so that is another indication where you could use a nerve biopsy. Now, in genetic neuropathies, earlier we used to do those biopsies, but now we don't do. Amyloid would be a third indication if you are suspecting amyloidosis, because you will need a tissue diagnosis. If you could get it from somewhere else, like a fat pad biopsy, abdominal fat or rectal fat pad, but if you are not getting that, then probably amyloid neuropathy would also be an indication when you are strongly suspecting, but there would be small fiber autonomic involvement. In those cases, you will strongly suspect amyloid. And then you should usually get something in the serum protein electrophoresis. You should do a complete, there is a myeloma panel where they do a serum protein, serum immunofixation, light chain, urinary light chain. So in those cases, before doing a biopsy, these all should be done. So my experience with amyloid, I have seen 1 or 2 cases, not much. It's rare. Pardon? Thank you.
Thank you for the answer to all the queries. Very well explained. Thank you.
Dr. Ashish, the most common form which we encounter is diabetic peripheral neuropathy. Do we have any particular agent which can modify the natural course of neuropathy?
So there are several
evaluate the thing.
There are several agents which are tried, but I think they are not very useful. They may help somewhat, but the evidence is rather poor for them. So main thing is to control the blood sugar, the glycemic profile, the other vascular risk factors, and try to control the pain and a good rehab. That would be my suggestion.
Thank you. Thanks for very nice presentation.
Thank you, sir.
I will now request President AMA Dr. Ashok Kumar Mishra, Secretary Dr. Ashutosh Gupta, and Organizing Secretary Dr. Gulab Soni to please honor the speaker and chairpersons. I will request Dr. J.V. Rai, past President AMA, to please come on stage to accompany them. I will also like to invite on stage Dr. Prabal Niyogi sir and Dr. Urmi Niyogi ma'am to please join in honoring the speaker and chairpersons of the Dr. K.S. Niyogi oration. Dr. K.S. Niyogi has left behind a rich legacy, which is very ably carried forward by his able son, Dr. Prabal Niyogi, Professor, Surgery Department, Motilal Nehru Medical College. Dr. Niyogi is a brilliant surgeon, a teacher par excellence, and a blazingly fine clinician. He adorns the seat of President of the Association of Surgeons of India. And it is an honor that he is with us today.